Hi, it's Dr. Centeno, and thank you for joining us here today. You've got the power. Today, I think we were planning on talking about the process for a CCI telemedicine eval, but lines got crossed there a little bit, and there was a plan for me to talk about the Grand Cayman site today. So I'll talk briefly about the Grand Cayman site, let you know what that's all about, and then we'll go to questions. Questions can be about anything, whether that's about Grand Cayman site, any of the procedures that Regenexx offers, or if there's any questions, obviously, about CCI, etc. So let's start first with just a short introduction to why the Grand Cayman site is different. And I'm going to go ahead and share my screen here. Okay, that seems to have worked. So we'll start with the Grand Cayman site. You should be able to see that. So again, today we're going to talk about what's different about the Cayman Islands Regenexx affiliate, and then we'll probably get to the topic we had planned, which was talk about a telemedicine visit on Monday. So what's different about the Grand Cayman site is that this site licensed our culture expansion technology. And culture expansion is growing more stem cells from your bone marrow in the lab. So we're literally expanding the number of cells. And how high does that go? Somewhere between 100 and 1,000x of what we take. So we can grow them out quite a bit. Now there is a time there where those cells are healthier. So we can't grow them out indefinitely. And just to mention, everything I'm talking about here refers to what's done in Grand Cayman by the site that we licensed to do this. So we're not talking about stuff that can be done in the United States at all, and not talking about stuff that we do in the United States at all. We only do this in Grand Cayman, and that site is independently owned and operated by a provider down there. Another thing, getting back to culture expansion, that's different about culture expansion is that these cells can be saved in cryopreservation for future use. So what that means is sometimes that's an advantage. Many athletes that we've treated find it's an advantage because they can save their younger cells, and they get those younger cells when they're older. Obviously, it's an advantage because we can save a number of treatments from a single bone marrow aspirate. Now, why would someone use this culture expansion technology versus just a same-day bone marrow concentrate procedure? And the first biggest thing we probably see down there is someone who needs lots of different areas treated with stem cells. So it's not uncommon in Grand Cayman for me or one of the other doctors that goes down there, and that's really any of the doctors on our Regenexx network, to treat 3, 4, 5, 6, 7, 8 different sites with stem cells. Another indication is moderate or more advanced hip arthritis tends to do better with more stem cells in our clinical experience. And then recalcitrant lumbar disc bulges. Now, many times you don't really need to treat the disc directly, and patients do well, but when they don't, and you really need to get rid of the bulge without surgery, we have a technology down there that we can inject into the disc bulge that in our clinical experience reduces that disc bulge size. So what are the rules of the Grand Cayman site? Because it's a little different. You need to travel to Cayman to get the cells taken out, or the bone marrow aspirate. You need to be treated in Cayman, and the cells can't be shipped to the US or elsewhere. They have to stay in Cayman. Why can't this be done in the United States? Well, the US FDA considers culture expanded cells a prescription drug, even if they're your cells. Now, we've got that technology going through an FDA approval process here in the United States, but that takes a long time. The Cayman government views it very differently. They view that if it's your cells, is the practice of medicine. So that's what's different about the Cayman affiliate. Now, I know I've got a lot of CCI patients that watch this, and regrettably, Grand Cayman is not a site where we generally treat most of our CCI patients, simply because the setup to do things like the PICL procedure really isn't down there. So not quite sure that's going to help very many CCI patients, but other types of issues are treated down there quite frequently. So in summary, the Cayman Islands Regenexx affiliate is different than our US affiliates in that they're allowed to use culture expanded cells, and we've licensed that technology to them. And then the doctors on the Regenexx network, some of them, not all of them, take their patients down there that need that type of technology. So let me stop sharing and see if I have any questions to answer here. Again, questions can be about this or really anything else. Okay, so questions, let me get to those. Bethany, hi, Dr. Centeno. I had my PICL 2 days ago, just recovering, but wanted to know if a lower stem cell count affects success of PICL. Mine were 522 million. I took all of your supplements for a month before and will continue to do so. Sure, Bethany. So first thing is that's a total nucleated cell count. So a TNCC or total nucleated cell count is different than a stem cell count. A certain percentage of the bone marrow concentrate nucleated cells are stem cells. But we have correlated that TNCC number, the total cells, with outcomes for things like knee osteoarthritis. So for instance, for knee osteoarthritis, the minimum is 400 million cells. So you're over that. And obviously we're not talking about knee osteoarthritis here, which requires more cells. So no, that's not a concerning number at all. And we're really talking about a threshold issue. So in all the research on either cell content, total nucleated cells, or stem cell content, like we just published recently, it's a threshold. So as long as you get over the threshold, you're fine. The threshold for knees is 400 million, but I suspect for ligament healing, far, far lower than that. So not a problem at all. Eliza, hello. Thank you so much, doctor. Thank you, Eliza. Liam, for CCI, should neck movements that make cracks and pops be avoided as much as possible? My C1, C2, maybe facets pop when I extend my head back. I also have loud cracks on the left side of my CCJ. If I rotate head left and lateral side, bend right, vice versa for opposite side. This just using neck muscles, no hands. Pops feel like they relieve some joint stiffness and increase neck range of motion. You know, I wouldn't be too concerned about it. It sounds like what you're describing is sort of the crack that you hear, can't do it right now, with your knuckles. And we know that that's pushing little oxygen bubbles, or really taking big ones and making them into smaller ones within the joint. Now, it's certainly possible that it's also related to instability if you've got CCI. So I certainly wouldn't do it if it makes it feel worse. But if it doesn't make it feel worse, I don't think it's a problem at all. Now, obviously, what could be a problem if someone was taking your head and moving it, that kind of thing. But for you to do it yourself, no, not that concerning. Diana, I continue to have sensation of swallowing a bone deep near my hyoid with crepitus followed by head wobbling, literally. Is it possible to have a lesser or greater horn or even calcified stylohyoid ligament catch on something that would move upper skull bones? Not that would move upper skull bones, no. Now, certainly if you're getting irritation of the 9th cranial nerve, that can provide, that could irritate the back of the throat. So you could be feeling that. Excuse me. You could also just be feeling a general sense of instability. That's possible. Why is the instability worse, it sounds like after the crepitus, you could just literally have C1, C2 sort of going out into strange positions. But no, those ligaments wouldn't be able to literally displace the skull bones. What causes sensation of skull sliding forward and back to start after recent AO treatment? Could be the C0, C1 joint. Something to consider would be the depth of that joint on your MRI or CT scan. So the theory is that deep-seated joints, and there's a way to do that calculus and look how deep-seated the joint is that's been described in the literature. The theory is that deep-seated joints prevent that, but that shallow C0, C1 joints with instability can cause what it is you're talking about. So it'd be interesting to do that measurement on your C0, C1 joint to see if it is one of those joints that's very shallow in combination with instability causing movement of the skull and the atlas. Deanna, are there benefits to getting upper cervical PRP at Colorado site versus Cayman? Yeah, Deanna, we generally don't do upper cervical work in Cayman. I was just talking about that on the short little presentation I gave. That's pretty much limited to Colorado, primarily because the tools we have in Colorado to do upper cervical work are better than the tools we have in Cayman. Liam, for a very functional CCI patient like me, for the months following PICL, should the head and neck be kept as neutral or aligned as possible and limit movement, or should the patient use their neck as it would normally? Yeah, really, as you would normally. Now, certainly if you were involved in exercises or other things that were irritating your neck, then we'd ask you to not do that. But if you figured out, sort of like many CCI patients do, kind of the box that you can live in that keeps everything good, then you're good to stay in that box. Diana, I have trouble nodding yes since I tripped. Bonehead zigzags and random pass. Dr. Rosa mentioned that I likely have damaged AO capsular joints. Yeah, so that's the C0, C1 joint that we were talking about just before. Diana, are culture expanded cells dangerous, i.e. breed mutations? No, we've actually published on that a number of different times. I think we've published the largest safety orthopedic safety papers on earth for culture expanded cells. So not dangerous in that way. Now, is it possible that if you did it wrong, i.e. that you were irresponsibly culturing and you kept them in culture forever to try to get the most number of cells, and I've seen some sites try to do that, then that could create some dangerous things. But no, not the way we're doing it in Grand Cayman or have been since 2005. Diana, is recumbent biking safe for CCI? My head wobbles so much with brace when I walk, so trying to see how I can get exercise. Yeah, recumbent would be pretty good. So I don't think there'll be any issues there, Diana, with a recumbent bike, as long as you can tolerate it. Eliza, I had a microdiscectomy almost 2 years ago. After that procedure, I started with worse symptoms, neuropathy in both legs. For the first time, I've had 2 disc seal procedures, last one a month ago, L4-5, L5S1. He mentioned that if I don't get enough improvement, he recommends stem cells directly to the area. My symptoms are low back pain, neuropathy in both legs, burning pain. You know, Eliza, I have to know more about what's going on. It sounds like if you've had disc seal procedures, they think there could be an annular tear, but if you've had 2 of those and it's not moved the needle, then probably not an annular tear causing that issue. We don't use the disc seal procedure. Our focus would have been to stabilize the area by injecting the ligaments and then treat the nerves directly with platelet lysate. So it's a very, very different approach. As far as injecting anything into the disc, there's always a 1 in 200 chance of discitis. Now, if you've got a continued disc bulge and it's thought that you do need to inject into the disc, then you can use things like bone marrow concentrate or PRP in the disc to try to help, or the culture expanded cells that we use down in Grand Cayman. But we don't use disc seal as a treatment at all. Submitted Harry Winston. Hope you had a wonderful time. Glad to see you're back. Thank you. If I travel to the stage for posterior upper neck injections, how long would I need to wait for a PICL procedure? You know, we'd want to give that a good 6 weeks to 8 weeks, Harry, to see where you end up, to see if you even need a PICL procedure if we're going to start posterior. Obviously, our hope would be that you wouldn't, right? Bethany, when looking at my imaging during physical exam, you notice there may be a cyst on the C2 dens. If I recall that, could that affect the healing process? Bethany, just put down there that you're giving me permission to discuss your confidential medical history here online. The only concern is that kind of pushes the limits with the laws around HIPAA. But if you put it in writing in the comments that you're okay with me talking about this, I'm happy to. But you know, we doctors have this HIPAA thing that we've got to obviously stick by. So just make sure you put that in the comments, and then I'll be happy to talk about it. Brian, 5 weeks out from Regenexx CIA and intradiscal. I feel biomechanical improvements in the quality of joint surfaces, but these seem fragile and vulnerable to damage from seemingly innocuous actions. These instances, same surface improvement ostensibly last and the disc aggravated. No, Brian, you know, I think you're just really not far enough out when it comes to any kind of intradiscal treatment. Those tend to take much, much longer, on the order of 3 to 4 months to fully see the effects. So I think you're just not that far out. Now, would I take up marathon running right now? No. Or would I add in anything else that you're not normally doing? No. But doesn't sound like a big problem to me. Submitted advanced by Mary Scopes. A friend recommended I come. So glad. No one I found seems to actually know how to treat CCI. She sent me a link to a CCI book. I'm excited to learn more. Is there an age limit for a PICL? Yeah, so Mary, no real age limit at this point. We don't really see a big correlation with with age at this juncture. Diana, Centeno, is that shallow joint at C01 and sliding sensation dangerous? Yeah, it doesn't have to be dangerous. Certainly, if the skull is moving on C1, that's not a good thing. So you want to get those ligaments that would control that tightened down. But if you just remind me, we can do that math and measurement for the depth of the joint and see if you happen to be one of those people that has a very shallow joint versus a very deep 0-1. Mercia, Dr. is it too early to see an osteopath or a PT 3 weeks after PICL? I have weakness, burning feeling in my arms, probably due to pinched nerves. No, shouldn't be a problem. But again, I would go back directly to the doctor that did your procedure and make sure that he can review your history and give the thumbs up for something like that. Becky, Dr. Centeno, why do you believe so many with CCI get MCAS? I think MCAS is associated with loose ligaments, and people with loose ligaments tend to have more CCI. So I think that's the relationship we're probably seeing there. Submitted by Sherry Scott. How long do you need to be in Grand Cayman? What's the time between the first part when you're getting the cells and when you're ready for injection? Yes, there's 2 ways to do it. One way is to go down for a single trip. And a single trip format, you're going to be down there about 10 to 12 days. You can also do a double trip where you do 1 trip for the BMA to give the cells, and then you come back for the re-injection. And that, because we're going to freeze the cells down, doesn't really matter how far apart those are. So either way, it's fine. Christine, do you treat CSF leaks? Because I think I have CCI and CSF leaks. We do treat CSF leaks if they're in the spine. So we will do blood patching, usually using platelet-rich plasma, and that tends to work well. But just realize that diagnosis of CCI leaks in the spine is not always an easy thing to do, as I've brought up here before. Okay, Bethany, thank you. So yeah, as you know, you had a small little cyst or a bone cyst in the dens or C2. That's interesting because we don't normally see bone cysts there. Bone cysts are commonly seen in advanced hip arthritis and advanced knee arthritis, things like that. And what a bone cyst represents is that that part of the bone has died off and then walled off. So once it gets walled off, there's no living bone inside. The good news is that the body tends to use that method to keep the structural strength, or most of it. But it does mean two things, right? On the one side, it means that that area has had some trauma because something had to injure the bone. And then on the other side, it means that there's some reason the bone couldn't heal. Now, perhaps it was because it was too traumatized. Perhaps it was because there's some underlying osteoporosis or other bone metabolism issues. Again, we tend to see those things commonly in more advanced arthritis of the peripheral joints. We don't tend to commonly see them in C2. So what that would mean to me is at some point you had some trauma to C2 and that area just wasn't able to fully heal. Does it mean anything adverse? No, I think it's just more circumstantial evidence that there's problems in the upper cervical spine. Becky, if one has MCAS, will you still do the PICL and PRP? I would like to feel like it's under control somewhat, but what are your thoughts? Yeah, Becky, at any given week or month, we probably have 20% of our patients who carry an MCAS diagnosis. So we're used to dealing with MCAS as part of what it is we do. Elijah, do stem cells and PRP interfere with what I've had? What you just answered me. I want to get that done. Stem cells, bone marrow, trying to get better for back pain and nerve pains. If you mean, does it interfere with disc seal? It shouldn't. I mean, again, the purpose of the concept behind disc seal would be injecting a fibrin glue to see if the tear in the annulus would heal. Now, if you are more than a couple months out from a disc seal, let's say, and nothing's really happened, and certainly a second one, then that's not working. We're either not healing the annular tear or there's something else causing the problem. So as long as you're at that failure point, there shouldn't be any issue. Randy, after a double discectomy at L4, 5, and S1, there are still nerve issues and foot drop of my left leg, a lot of numbness and weakness. Regenexx helped us at this point with getting nerve damage fixed. Yeah, Randy, the best I can tell you is we've seen a lot of patients in that category. One patient that comes to mind is a guy who is a big-time CEO of a Fortune 500 company, had a bad back surgery, got a big infection with his back surgery, had nerve damage, was wearing an ankle foot orthosis or an AFO to walk, meaning he couldn't pick his foot up at all. And we were able to treat the nerve using platelet lysate hydrodissection and platelet epidurals, and eventually got him to the point where he could go back and hunt. Now, he did sometimes still need his AFO, but he was much, much more functional, much more able not to use it, and able to do things on uneven ground, which, as you probably have recognized, having a foot drop and doing anything on uneven ground is no fun. So yes, we have seen that work. Christine, I will do a maybe tethered cord release and after do PICL. How long between these two treatments? Christine, you got it backwards. And just to let you know, I'm going to caution you not to do a tethered cord release and then a PICL, meaning that you're putting a much more invasive procedure first that you may or may not need in front of a much less invasive procedure. And patients are kept safe by doing the least invasive thing that's likely to help. So that would mean PICL. And if you still have issues, then tethered cord, but never tethered cord and then PICL. That would be backwards. You're just exposing yourself there to more risk than you need to. And that kind of violates everything I teach here on You've Got the Power. Again, least invasive thing that's the most likely to help always goes before something that's more invasive. Tethered cord means that we're permanently altering the biomechanics or tethered cord release of your central nervous system. There's no going back once we do that, and that's a much more invasive procedure than something like a PICL. Edward, I know you've stated that PICL is not treated Grand Cayman, but would posterior injections with culture expanded cells in the upper facets ligaments be possible? Ed, it is possible. We do that there, but we can't offer the PICL there. And while the staff in Grand Cayman, when it comes to the upper cervical spine, has been educated through the years because it's part of my daily practice, I've had to get them up to snuff. Are they as experienced and helping me do those procedures as the staff in Colorado? They are not. So can it be done? Yes. Is it my first choice to do an upper cervical patient there? It is not. And that's not because it's not a fantastic place. I see all sorts of patients there. It's just for upper cervical issues, the amount of knowledge it takes to do those safely is just really, really big. And I wouldn't trust 99.9% of the places in the US either to do an upper cervical procedure, because I'm going to get a rad tech that has never done that or hasn't done it very often and can't assist me in getting it done safely. Now, at least in Grand Cayman, I've gotten staff educated enough where they can assist me in getting it done safely. But are they as experienced as Colorado, where we do this all day, every day? They're not, because they don't do it all day, every day. Era, what are the chances correcting AAI? My skull has been tilting back the last 5 weeks with axis. 5 weeks, the axis with C1 falls back, causing the skull to slide off and backwards, putting the front side of my spine. Era, the first thing would be, can we see that on DMX? So that's the first thing. And assuming that's happening, I'd need to know how much motion it is we're talking about to give you some idea of whether or not we'd be able to get rid of what you're describing. Diana, do you think injecting my posterior ligaments plus C0 through C2 will help me AO joint sliding sensation? Sure, but again, just realize that if we're talking about 0-1, right, we're talking about something that is stabilized not only by the capsular ligament of the facet joint at 0-1, but also by the tension of the alar ligaments that connect C2 to the skull, and C1 is sandwiched in there. So if there's good tension on those alars, then you've got a really nice sandwich that's going to move together, meaning the C1 is captured in between those two. If the alars are loose, now we've got sloppy motion in the atlas. So it's not only the capsular ligaments, but it's the tension in those alar ligaments that help to control what's happening between the skull and C1. Eliza, stem cells, bone marrow better than endoscopy, discectomy. A doctor told me with endoscopy, discectomy. He will seal the disc, but I cannot find information about that anywhere. Yeah, I mean, discectomy is discectomy, right? There's all sorts of research showing it's not all that successful. I think the reason why it's not all that successful is because we're removing a part of the disc that doesn't grow back. So there's a percentage of patients that then just reherniate and have the same problem. We also have to do some damage to get there, which damages that functional spinal unit and then can cause new problems. So I don't know your clinical situation. I'd have to review your information to make a comment about that. But in general, we don't have a lot of research showing that discectomy is effective. And that's, again, probably because there's a certain percentage of people where we're doing more harm than good than harm. Arir, hello, doctor. Do you need less applications of Cayman Islands with this stem cell therapy? I'm hearing about it for the first time, and I know the clinic in Colorado, excuse my English. I'm not sure what you mean by applications, so maybe clarify that for me. Eliza, checking second opinion. Some doctors, they just want surgery. What are your thoughts on just surgery approach? Yeah, Elijah, I don't know your clinical situation. I haven't looked at your MRI. I can say in general that spine surgery in the lumbar spine is usually a bad idea. Now, are there patients that really need it? There are, but those patients are few and far between. The research in spine surgery, whether it be a discectomy or a lumbar fusion, shows that it's not really all that effective for all the reasons I talked about. So I'm not a big fan of sending my patients for spine surgery if there are other ways to treat them. Now, like I said, once in a while you see a patient and there's no other option. But to my mind, based on what I've observed, that's maybe 1 in 10 patients that currently get lumbar spine surgery. Deanna, will a carnivore diet impact PRP quality? Carnivore diet. I'm assuming you mean a high protein diet. Maybe tell me a little bit more about what you would classify as a carnivore diet. Eliza, I saw you in the fasting documentary. You're awesome. How many days fasting regimen before going Regenexx to help the procedure? You know, I would say all that's really required would be fasting for 6 hours prior to the procedure. Now, we do have some data that shows that fasting can help your stem cells. So if you really wanted to do that, something like a fasting mimicking diet might be much, much better. I've in the past used that Prolon, Prolon, and it's not inexpensive, but it's pretty cool. It comes in a package like this. You get a little box for each day that, you know, this is what you can eat on day 1, day 2, day 3, day 4, day 5. So if you really wanted to supercharge your stem cells without too much pain, if you will, that Prolon, Prolon program I've used in the past, and it's pretty good. That's what I'd recommend. So that's a 5-day fasting mimicking diet. Christine, have you thinking about travel in Europe for just a month or something, do PICL? No, Christine, that doesn't work, regrettably. I wish it would, but there'll be all sorts of reasons why it wouldn't work. The first would be that I'd have to get licensed in Europe. The second would be, obviously, I'd have to get malpractice insurance in Europe. The third would be I'd have to find someone that had all the equipment I needed, which is not going to be possible. We use a dual C-arm setup that I'm not going to find any place in Europe. We have an endoscopy unit in the OR, which I'm not going to find in Europe. And I'm also not going to find a rad tech that knows which end is up to help me accomplish what I'm trying to get done. So regrettably, that the ability to do it in Europe is just not there at this point. Diana, do grade 3 lesions of both alars and transverse always translate to having CCI? If what you mean is change in signal intensity on an MRI, there's a couple things to sort out there and to unpack. The first thing would be, Are we talking about a high-grade closed bore magnet, because that's the only grading system that's been put out there, or an open? On a closed bore high field magnet, that would be the studies by Crockiness. And Crockiness never took that data on the grade of an alar ligament injury, or really signal change, and looked at instability. So no one really knows. If we're talking about an open, we don't have any grading research on lesions in open MRIs. So all bets are off on that one. Edward, can PICL be done with other orthobiologics if one doesn't respond to BMC? I'm assuming something like Prolo, being neurolytic, wouldn't be safe in that area. Yeah, Prolo could be a potential disaster. In fact, I just had this conversation with somebody. I think it's worth having here. So this is a patient that went to a clinic for some blind prolotherapy. Now, this clinic does use some basic X-ray guidance, but doesn't really have any qualifications to do advanced spinal injections using contrast. So 2 weeks after this whole thing, patient develops, quote, transverse myelitis. In looking at the MRI with her, she's got a lesion at C3-4. Now, her neurologist, not knowing really anything about prolotherapy, said, oh, prolotherapy causes inflammation, so maybe this is an autoimmune condition due to the prolotherapy. Doesn't make any sense at all in understanding acute inflammation versus the kind of inflammation that you'd get with autoimmune. So I think the neurologist was way over their pay grade there talking about that. But what you just brought up is that Prolo is neurolytic, right? So how does prolotherapy work? Prolotherapy is hypertonic. And hypertonic means it's more concentrated than your body's own solutions. Now, that's a powerful effect. Let me demonstrate tonicity and how powerful it is. So your blood is 0.9% concentration, and distilled water is 0%. So only just about a 1% difference in concentration. But if I take your red blood cells and I put them in distilled water, instead of 0.9% saline, which is what your blood is, those red blood cells will all pop in about 10 seconds. So just a 1% change in concentration has a dramatic impact on cells. Now, with the average prolotherapy solution, we're talking about at least 10 to 15% change in concentration. So what does prolotherapy solution do? It causes local cell death. Now, that's fine if you're in a ligament. That's just like debriding the ligament surgically, right? It's just a chemical debridement. You have certain cells that die, but not nearly all of them. And that causes a brief inflammatory healing reaction, which can be very positive. But if that same stuff, as you just brought up, gets around nerves, that's a bad day for everyone. That will kill the nerve. So in this particular lady, I was like, what's more likely, that you suddenly developed an autoimmune transverse myelitis 2 weeks after Prolo, or they inadvertently injected some of that prolotherapy solution intrathecal around the spinal cord, and it wasn't enough to cause a high spinal, thank God, because we wouldn't have this conversation if it was. But it was enough to cause some injury to the spinal cord itself, which then shows up as this bright lesion, this inflamed area within the spinal cord, and it would take about 2 weeks for the cells to die. That's called Ehlerian degeneration. So thank you for bringing that up, Ed. That prolotherapy solution is toxic to nerves. So no, yeah, we couldn't use it in the PICL for that reason. Sorry, I prefer to ask like this. What are the benefits of treatment in the Cayman Islands? Yeah, so if you go back to the beginning, I go through that whole little lecture. So this will be able to be watched, but basically, the big benefit is the ability to save cells for future use, number one. Number two, growing more cells than we can grow locally. So those are the two big differences in Grand Cayman. Carnivore is typically just animal-based, mainly meat, but some eggs, whole milk, somebody have low histamine foods. I don't think that's a problem at all for anything that we're doing. So that would be fine. Eliza, just to give you thanks, you answered all my questions. You're answering everybody's questions. You're an awesome service. Well, thank you, Eliza. Yeah, we do this, or I try to do this if I can twice a week, just because, listen, I realize the medical care system is all messed up. I realize it's hard these days to get doctors to talk to you. In fact, I was just talking to a patient about this today. I think that that's why a lot of patients tend to gravitate towards functional medicine, because you finally have docs that'll spend time and talk, because the average doc is on the traditional side is forced to see ungodly amounts of patients per day, 20, 30, 40, 50, just to make ends meet. So the goal here is to try to answer questions and make sure everyone's informed. Edward, what's the minimum percentage or improvement on a repeat DMX for classified as real improvement on instability? Yeah, so that comes down to the error in the reading, right? Every measurement that you can take has a standard error, meaning if 5 different people measure this, how far off are they going to be from each other? So let's say we're talking about 6 millimeters. The error rate on that is going to be probably positive, negative a millimeter or so, and maybe a little bit. So 1 millimeter in total, so a half millimeter on each side. So we could get measurements from 5.5 to 6.5. So obviously we'd want to see something greater than that. So we'd want to see, let's say, a 6 go to a 4.5. Something outside of that error or standard measurement of error. Or error measurement, sorry. Edward, how are DMX machines calibrated to be able to make measurements off the DICOM file? Is it up to the same standard? Yeah, Edward, we see that as a problem in DMX. And that is that on an MRI machine in a DICOM file, the measurements are validated when the machine is set up. So we know with reasonable accuracy if it's 6 millimeters or 4 millimeters or 8 millimeters. However, not really the same in a DMX. We see, for instance, some of the DMX owners trying to put a little item, if you will, or something that can be seen on the film, on the image intensifier or on the collector for the beam. The problem with that is that would need, so let's say I've got a DMX that's like this, right? And I put this thing over here. And so I know how many millimeters this is, and I'm broadcasting a beam from here and it's being collected over there. Now I've got my little thing over here. I know, let's say it's 10 millimeters, but for that to be accurate, this little thing would have to be in the same plane as my neck bones. And by having it all the way out here, I've created some magnification effect so that 10 millimeters out here is not the same as 10 millimeters in here. So measurements on DMX tend to be a little bit of a mess because of that. Hence, what you're bringing up is that we will look at a DICOM file and then transpose that onto a DMX to double check the measurement. And there are times when we see it's pretty close, and there are times that we see it's way out there. So that's why we do that, to double check those measurements so that everyone is looking at the same measurements and we're not seeing DMX measurements that are wildly different from one place to the next. Megan, asking for a friend, would a scalenectomy for treatment with thoracic outlet syndrome further destabilize? Oh yeah. Yeah. I mean, so scalings are interesting, right? If you think about a sailboat mast, you've got all those wires going up to the mast that you see. There's lots of names for those that can be called shrouds, but they stabilize the mast. And if you think of the neck as a sailboat mast, the neck bones, then the scalings are those wires. So cutting those wires will destabilize the neck. So that would be the least favorable thing to do. Now, listen, are there people out there that might need that? There are. But would you put it high in your list of things to do first, second, third, fourth, or fifth? No, for that reason. Diana, I've never had a proper ADI calculated. I almost fainted in flexion with my first x-rays, and doc said I was normal there with the sliding sensation, mean ADI too large. No, really what you're talking about is not ADI, but you're talking about the skull moving on the atlas. ADI would be the atlas moving against C2 or the dents. Okay, guys, any other questions I can answer? 1:47, so I'll go another 5 minutes or so, or at least 1:47 my time, 47 after whatever hour you're at. If you could throw your questions on here, happy to answer any other questions you have. Again, today we've been talking about Grand Cayman. What we've been talking about there is what happens there, why it's different, the ability to culture cells, et cetera, et cetera. Oh yeah, Dana, looking forward to see you as well. Any other questions I can answer that you might have out there? Okay, guys. Well, you all have a wonderful weekend. I will be here, I believe, on Monday. So on Monday, we'll try to get to what we were supposed to do today, which is the telemedicine for CCI and how that runs. We'll try to get to that one. And then Fat John had some questions that didn't come through. Yeah, Fat John, I tell you what, maybe you can just send them to my email, which I think you have, but if you don't, I'm going to put it right here in the comments. So this is the email that goes to my desk, and just send me those questions, and I'll try to answer them via email, or obviously you can just wait. And I can do those on Monday as well. Monday, 1 o'clock Mountain. Okay, guys, thank you so much. Have a wonderful weekend.